Greetings, everyone, and welcome. This is Dr. Lori Laws, and I am presenting Shoring Up the Foundation, Healing-Centered Strategies for Nurse Educators. And this is a presentation I gave at the National League of Nursing Educational Summit. So let us get started on learning how we can better support our students and ourselves. There's no conflict of interest for me to report at this time. And let me tell you a little bit about myself. Here in Tucson, Arizona, I'm known as Wildcat for Life, which means I graduated and alumna from the University of Arizona's College of Nursing, where I did my graduate studies. I continued on to do 2 postdoctorate fellowships, both of which were in integrative health. I went on to teach and am still teaching for both the social and behavioral sciences and also the College of Nursing in the BSN program with an integrative health focus. I work a lot with nurses who have been traumatized and early career nurses, and most of that is trauma recovery work. So that's a little bit about me by way of survey. Let's take a look at you. We're going to do a little old school. If you were live with me right now, you'd hold up a finger 1 through 4, and let me know to what degree you are experiencing student resilience challenges. The usual amount, more than usual, a lot more than usual, or oh my goodness, too much, a lot. And that's many of us right now. And then just by way of kind of grounding it into the core concepts of this work is how familiar are you with polyvagal theory? And you can use your hand to kind of determine if you're not really familiar. It sounds a little bit familiar. I'm pretty familiar, very familiar. And I would put up 5 fingers if I were in the audience because it's my life. It has become my life, as you'll see. And so then last question is, what is your comfort level supporting students as they navigate their nervous system as a self-caring foundation? And 1 through 4, again, maybe a little, I'm open but not comfortable. Number 3, I'm comfortable. Or number 4, I'm already on it, which would be great if that were the case. Just a little disclaimer that some of the topics that we're going to discuss today might be sensitive to some, and so please prioritize your comfort, your regulation, and your well-being. Today we're going to talk about Foley's middle range theory of nurse psychological trauma, as well as the current literature base surrounding that topic. We'll discuss some signs of student traumatization and how we can guide them in navigating and regulating their nervous system. And then we'll have a couple of practices at the end that you can translate right into your teaching practice, however is useful to you. So let's take a look at the basic approaches and assumptions and major theories. I really like Gabor Mate's definition of trauma, which is it's not what happens to you, it's what happens inside of you as a result of what happened to you. So let's take a look at what the American Association of Colleges of Nursing has to say on that. Their guideline is that we are to assume everyone has experienced some type of trauma in their lives, including ourselves and our students, and everyone on our interprofessional teams, our colleagues, and so forth. So the goal is not to know everyone's trauma history. In fact, that would be a poor idea and potentially re-traumatizing. And we're not really trying to discover what's happened. What we're really trying to do is take a trauma-informed approach to their education. And this is from 2021 and is relevant today, that the need for trauma-informed education is critical. And that's why I'm here. The student-educator connection is an essential part of being human and a foundation for regulation and managing stress during school. It's mission critical that we really start looking at the traumas and trauma responses, which are really adaptations and not choices, that are showing up in our students when we are educating them. There's a study by Spur et al., and they took a look at 196 BSN students in nurse well-being and resilience. And you'll see in the lower left here that there are a lot of positive attributes that our students come in with, and I'm sure you're seeing those in your students. We have healthy, strong, well, proud, capable students who are really content with their decision to join the profession of nursing. With that came some negative attributes right here, which were a lot of reports of being depressed and anxious. And I know that this has been talked about and is being explored robustly in nursing curricula and faculty bodies across the globe. And so we're looking at, well, they're depressed, they're anxious, maybe are they burned out? Are they having traumatic stress? And that's what we're really going to focus on today, because sometimes these get all overlapping in how we use our language. And so we're going to take a look at and discuss how these findings really illustrate the importance for nursing faculty to develop support strategies for lowering burnout, maybe alleviating depression and anxiety, if indeed that is what the student is experiencing, by addressing their traumatic stress response. So it's not really, when we start unpacking the literature on these topics, it's not necessarily about resilience. There's a need to investigate the causes of stress and a need to recognize the different interventions that we may need to develop that arise from the nature of our work. And that also includes whatever exposure we had to traumatic events in our own personal life, because we just don't separate ourselves from that, from all of our lived experience, right? Nor do our students. And also that which results from excessive workload, staff shortages, lack of support, and the list goes on. And so you'll see in a minute, when we use Foley's middle range theory to frame that, what's really being said here in 2019, which Foley formalized in her middle range theory in 2022, I believe, is differentiating between avoidable trauma exposure and unavoidable. And you can see here that some of these issues are completely avoidable, and they are system challenges. So always I recommend using the 4 R's from SAMHSA. In the presentation we have today, we're going to practice the first 3 R's, which is we're going to realize that trauma has widespread impacts and there's various pathways to recovery. We're going to recognize the signs and symptoms of trauma in our students and our coworkers and perhaps even ourselves. And we will learn how to respond by integrating the knowledge you learned here today into how you support your students in your classroom, in their clinical settings and beyond. And always the 4th R is we want to do what we can to resist re-traumatizing anyone, including ourselves. So let's take a look at Foley's middle range theory. And indeed, it was published in 2022. And this is such a powerful middle range theory. I highly, highly, highly recommend reading this. She also has a book out on this topic. And she breaks down and classifies avoidable and unavoidable traumas. So let's start on the left with the individual traumas that your students, and probably you and all of us, experience just as a part of being human. So some of us have experienced acute traumas, such as a car accident or falling out of a tree and breaking your arm. Many of us have experienced chronic trauma, which might be a chronic condition, a long-standing abuse or injustice or oppression. Complex trauma is just what we think it is any combination of these classifications of trauma you see here. Developmental trauma would be in utero, neonatal, birthing traumas, ACEs, attachment traumas, etc., and then neglect, which could be physical and emotional. So that's, each of us might have and likely has had some exposure to these in our personal life, and most assuredly your students have as well. Now on the right side, we get to nurse-specific traumas. All right, and we're trained somewhat to manage vicarious and secondary trauma. Historical trauma, sadly, an example of that would be nurses eating their own, which I know is not intentional, but because of the systematic oppression of nurses, over generations of nurses and being marginalized and disenfranchised and minimized through various forces and factors that gets transmitted from generation to nurse to the next generation of nurse. Workplace violence, whether that's at the hands or words or actions of our patients and their families, or through our colleagues in all sorts of lateral violence, incivilities, or workplace violences. There's system-induced trauma, which is trauma that is introduced through the system itself, which we all know all too well how problematic the healthcare systems are in this country and indeed across the globe, and they can often be a source of trauma of themselves. The one I think most are familiar with is insufficient resource trauma. This is short staffing. This is not having the right skill set, not the nurses don't have the right training and they're floated off to units that they aren't experts in. We don't have enough physical supplies to do our job. We don't have enough time to do our job. We have too high of patient-nurse ratios, etc. Second, victim trauma, that's something that might follow after an adverse event, say, or a sentinel event. And sadly, that's often secondary to insufficient resources or the system itself. So can be a complex trauma. And then trauma from disasters, which we're all prepared to varying degrees to manage those. So I took a look at this when I was reading this middle range theory. I'm like, wow, there's a lot that's avoidable here. And so I put sad faces by the fact that, yes, it's sad that nurses are exposed to vicarious or secondary trauma and the historical trauma that runs through our nursing lineage and the trauma from disasters. But we do get some education and training in those, and it is inherent. Those types of trauma exposures are inherent to the profession. And we sort of all knew that getting in, or we learned about it getting in, and we still continued. And same with our students. But the ones with the red circles, these are avoidable. And in my opinion, these are never events. Nurses should never be abused in any sort of way at work. The system should not traumatize them. We should not work with insufficient resources, and we shouldn't be put in positions to practice in a system that doesn't operate well and is under-resourced, that causes medication errors, adverse events, sentinel events, near misses, and then we carry the trauma with us when those things happen. And so I call those avoidable because oftentimes they're secondary to health system inadequacies. So there's a whole lot of red on this page, and I would like to help everyone learn how to thrive instead of just survive in their practices. So if we look at us as nurse educators, and we all bring with us our individual traumas, IT, and then we bring with us whatever nurse-specific traumas, because we're all in varying degrees of healing through those. Sometimes we can completely integrate and experience a trauma exposure, and many times we cannot. So we just look at our roles as nurse educators, and we're faculty, we're in the skills lab, we're in the clinical settings, we're precepting, and with us, we also embody any of the individual and nurse-specific traumas. Well, when we put the student in the middle of that and they bring in their individual traumas, it's like a trauma sandwich for them. It's a lot to feel and be exposed to so early on. So with that in mind, let us go into the next section of our conversation and really unpack in more detail using the lens of polyvagal theory, relational neuroscience, and transpersonal neurobiology, what's going on and what's going on with our students, maybe what's going on with ourselves, and what can we do about it, importantly. And let's see if I can get this to advance. It's every day's a new adventure with the advancer. So remembering that trauma is what happens inside of us as in response to what happened to us. In Van der Kolk's work, The Body Keeps Score, what we know is that unhealed, non-integrated trauma, it's embodied. It's essentially stored in the body, and it leaves an imprint in our body, our mind, our brain. Oftentimes it's stored in the fascia, muscles, bones, and most especially the neuroplexes that are distributed throughout the body. And so when these get awakened, when this awakening happens, when the non-integrated trauma arises, it can be very distressing to people who don't know how to navigate it, which is most of us. And then there's the relational piece that comes in, and many of us aren't able to integrate all of our trauma exposures fully because we don't have who we perceive we need with us at the time, before, during, and after an event. Now, that doesn't mean we didn't have people who didn't love and care about us. It doesn't mean, but they may not have been equipped. They themselves might have had unhealed trauma around that particular event. So this is how it kind of gets stored, and when it is time for it to be released for healing and further integrations, it's usually when the person feels very safe to do so, even subconsciously. So I really like Dr. Bruce Perry's perspective, and it really helps frame, looking at our students when we see behaviors that would be easy for us to dismiss as, uncooperative or stress or anxiety or depression or any number of things. Or we might have some sort of an opinion or perhaps even a judgment about some of those behaviors. And so I'm going to invite everyone to join Dr. Perry and all of us to really looking at through the lens of, I wonder what happened to you. What happened to us? What happened to them? As opposed to what's wrong with them. We're so conditioned as nurses to always be doing an assessment, finding what's not within normal limits and addressing that. And so it's a very subtle but powerful shift into just being openly curious and compassionate about, oh boy, I wonder what happened to that student. And then holding that space and being intentional about how you interact with them and maybe guide them to where they can navigate their nervous system a little more effectively. So Dr. Stephen Porges brought forth the polyvagal theory, which is a game changer in so many ways in terms of trauma healing. And you probably have learned about parts of this, so I'm going to move kind of quickly through polyvagal, but there's plenty of videos on my YouTube channel and in my upcoming book that will break this down in vast detail. But essentially, we have the autonomic nervous system and the vagus nerve. And when we're in ventral vagal here at the top of the ladder, it's hierarchical. You have to go 1, 2, 3. You can't skip any rungs on the ladder. So when we're in ventral vagal, it might be how we're feeling right now. We're enjoying a presentation, we're thinking it, we're open, we're receptive to learning, we're feeling somewhat calm, we're connected with one another as a in-person or a virtual community. So we feel safe and we're able to socially engage. But when we get stress that comes in, which stress is a natural part of life, depending on the nature of the stress, if it starts to feel like we can't manage or address that stress or the threat or the danger, the sympathetic nervous system comes online. And I know we all know the sympathetic nervous system intimately. I call it the all hands on deck circuit, and it's really active protection that puts us into sort of a fight or flight response. So we will either move towards the stimuli, and that might look like anger or rage, or we might move away from the stimuli, and that might look like worry or anxiety. Okay, and it's not necessarily a physical moving towards or away, but it could be. And if the sympathetic nervous system cannot address the stress, the threat, the danger, then the dorsal vagal circuit comes online, and this is the no hands on deck. It will shut you down. Your mitochondria are getting depleted. It's a passive protection where with partial or total immobilization. With your students, it's partial, where they might feel numb, shut down, trapped, hopeless, despair, etc. So how does this work then? You're telling me that the body, stored anything that wasn't integrated, whether it's individual or nurse-specific trauma. What does the system look like? And indeed, the system looks like this. You can see in the blue bubble around the body that this is what I call your repository. And your repository is the data bank of all unhealed, unintegrated trauma in varying degrees of healing, but it isn't fully integrated, stored in the places like your fascia bones, muscles, and neuroplexuses. And then there's our 3 circuits that we talked about on the previous slide. Now, Porges brought forth this really important concept called neuroception. And neuroception is the vigilance of the brain in the midbrain region that serves as the threat detector. So 24/7 neuroception occurs and it monitors external conditions and also your internal conditions, including your emotional state, including anything that is emerging or awakening or stored in your repository. All right, and so that's critical. So what happens is for your students, for all of us, is that if they are experiencing some sort of a stress response or a behavioral response, it's likely that their threat detector has signaled that there's some danger, and that could be real or perceived. It could be external, internal, or that which is in the repository. And so it's how you could have a group of 8 students going out on clinicals, and they 4 of them experience the same thing with the same patient, but they have 4 different responses, right? A wide array of behavioral responses that you observe in them. And the reason for that is because the threat detector and the repository are signaling, and no 2 of us have lived the same exact life. And so we're going to get different responses. And they can also, it's not as with all things physiology, right? It's never just black or white or 1, 2, 3. So you'll see there on the left are the 3 primary circuits that we talked about, and they can come online in varying degrees under different circumstances, as signaled by each individual person's threat detector that is reading the internal and external and repository cues for danger. And those hybrids, which are on the right, are kind of mixtures of the 3. And so we have the play hybrid, where you can joke with your co-workers over lunch and have playful banter, and you can play with your dog on the floor and those sorts of things, play with your kids. There's the stillness hybrid, which makes yoga and meditation and more contemplative behaviors, or writing, reading, anything still. Because notice both in play and stillness, we're feeling safe, right? And one has a little more energy, one has a little more stillness to it. But when we get down to the bottom 2 hybrids, fawning and freeze, the threat detector has said you are unsafe, right? And so maybe flight isn't available. Shutting down isn't, a dorsal vagal isn't available. And so a hybrid comes in, fawning. So I can't escape, I can't fight, I can't flee. So I'm going to please and appease. Or conversely, I am unsafe and I need to shut down because I feel like the danger is that great that I just can't. And I've heard my students say those exact words, I just can't. And it's not that they don't want to, they can't. So I like to look at the 3 circuits, which you can see in the blue box, and then the hybrids over here on the right as dimmer switches. Given the signals from the threat detector, who is 24/7 monitoring external, internal, and repository data and signaling as to which of these circuits or their hybrids are going to come online, It's not a binary situation, it's like a dimmer switch. And then you'll see over there in the stillness, even within two people who are in the stillness, they might have varying degrees of dimmer switch activity. So everything, think of it in terms of a spectrum rather than an on-off switch. It's really important to note that these are involuntary adaptations of the nervous system, all happening below the level of the prefrontal and frontal cortex. These are not conscious choices, not for any of us, not for you, not for me, not for our students. So what does that look like? In Dan Siegel's model of the hand, which I love, we're accustomed to dealing with our students when their upstairs brain is online, as is shown here. We have their cerebral cortex, prefrontal cortex. The brain is nestled, the limbic system is tucked in the thumb, and all of the mid and lower brain cells are represented underneath the purple line. So this is how we're accustomed to interacting with our colleagues and our students. But what happens is when they get an unintegrated trauma response, the upstairs brain, well, it flips its lid. It goes temporarily offline. And so what happens is the limbic system gets in the driver's seat. And the limbic system doesn't have any filters, doesn't have the ability to self-modulate much. And so this is really problematic. And this is where you see the behaviors that are overblown. They're shutting way down. The students are stressed disproportionate to the stressor, and oftentimes out of context. And so this is where it gets really challenging to manage if we don't know how to guide them in their nervous system. So when a student or a colleague or yourself flips your lid, again, it's not a conscious choice, it's an adaptation. Your upstairs brain is temporarily offline because it got hijacked by a trauma response, past or current. All right. And the downstairs brain is in the driver's seat, and it feels like you're stuck. It feels like you're broken. It's important to really remember that nobody's broken. This is how this person's nervous system adapted in response to what has happened to them. All right, so holding that compassionate space. So many of you have seen this slide in the left, which is how polyvagal theory is classically presented. And I want to draw your attention here to this little sine wave. I'm not going to go over all this, like most of us know all of this. But as our students and ourselves move through the day, we're somewhere in our ventral vagal where we can be socially engaged, we feel safe, we're grounded, we're able to do our learning and our teaching. And as we experience stress, our sympathetic circuit comes online, but it's still in this manageable I can. But the more it gets up here, the harder it is to be in I can, right? And so what Dr. Porges calls this sine wave over here is really the window of tolerance. And that's the goal. That's where we want to be. That's where we want our students to be. We want our patients to be. We want the whole planet to be in their window of tolerance, where there is, with the window wide open, right? We want to maximize that ventral vagal connection where we're just safe and secure and joyful and present. We want to be able to manage the stressors that come in with an appropriate sympathetic response. And what will close that window is if our sympathetic nervous system gets hyper aroused. We start moving up in here into this overwhelm. We go from I can to I can't. Right? And that's going to start closing that window of tolerance. And if that persists, the stimuli, we're going to get up here into the freeze response, right? And that's also that dorsal vagal is going to come online, and that's going to close the window. So as educators, our goal is to minimize these and maximize ventral vagal and manageable sympathetic responses. So you're like, well, how do I go about doing that? We're teaching self-care and, just not sustainable. In fact, I just recently had a meeting with educators in Sydney, Australia. And they said, well, we had this beautiful program, and it was a mindfulness-based program, and we devoted the first 7 minutes of each class session for students to come in and just to do a mindful practice that was facilitated, sometimes not. But we had like a certain percentage of our students where they were disruptive and they wouldn't sit still. And as the semester went on, we just asked the students if they wouldn't mind coming in, 5 to 7 minutes late because they were disrupting the others. And they were really frustrated about this. And I said, well, I understand. I understand the frustration on everyone's part because you're over here doing all of these beautiful self-caring practices. But for the students who are in their sympathetic circuit, stillness is not available to them. Right? They cannot be still. If you have cortisol, norepinephrine, and epinephrine coursing through your veins, and your autonomic nervous system is signaling that you're in flight or fight, being still isn't available. And so it's really matching, getting this regulated nervous system, the window of tolerance, and then putting those self-care practices on top of that. So we need to shore up the foundation, and that indeed is the title of this talk. And so in my work, I have 3 A's. I've developed a framework called Your Innate Care Plan, which is the 3 A's down here at the bottom, where we start first with the nervous system, and vagus nerve, etc. All right. And so having awareness, which you're getting today, you're going to learn how to attend to your nervous system here a little bit at the end, and how we can align that with how it manifests in our external world. And one of the practices that we'll do today is this microdoses matters practice. And then from there, we can go to the next tier of the pyramid, which is the balanced pyramid. And this is where we, traditional self-care practices of any sort. And if we start with the shoring up the foundation and continue to take good care of ourselves and our students and they themselves, then we can get to the 3 R's, which is really where we want to be: regulated in our nervous system, reconnected within ourselves and with one another, and restoring our healer's heart, which is what really brought us to the profession to begin with, and keeping that in focus. And all of this corresponds beautifully to Maslow's hierarchy, because starting with our nervous system as inner self-care has tremendous physiological benefits. Safety, that's what the threat detector is all about. And it helps us in our belonging and love domain, because we are mammals and we are built to co-regulate and heal with others. So that takes us to, okay, great. But now how do I help my students? What do I do with these behaviors? So let's start by taking a moment and looking at these student archetypes that I developed for you. We have Jordan, and Jordan is an overachiever. She is waiting for you before office hours, after office hours, walks you to and from class, wants to talk to you before lecture and after lecture, that sort of archetypal student. Then we have Gabby, who is just a compulsive and chronic overthinker, always anxious, chronically overthinking everything, to the point of maybe borderline being a little difficult to manage during test times or in simulations, because they're just so anxious. It's really hard to help them be present. Then we have Nathifa, who she gets a little controlling, and sometimes it looks like she might even be a little bullying to her peers and her coworkers. Taylor she really has a hard time focusing. Concentration is challenging for her, and she tends to be a little bit late, almost to everything. Riley is a very bright girl, completely capable of being a very high achieving student, that she struggles to kind of find her bootstraps and really, leans into her fellow students, her lab mates, her lab partners, and so forth. She has a hard time finding her own identity as a student nurse, and she has a tendency to be a little codependent in her relationships with others. And then we have Chin Mei, who has a hard time engaging and has been described as a sloth. Like, she moves really slow, she speaks slow, she's slow to respond to communications, etc. So you might have seen some of these. These are the most common archetypes that in the educators that I've talked with across the globe. These are the archetypes that emerge from those conversations in terms of students. So we're going to break into small groups here for just a couple of minutes and then just take a look at what might be going on. So we're seeing the behaviors, right? We're seeing the behaviors for each of those students. But now let's think about them in the context of polyvagal theory and trauma adaptation responses in terms of fawn, fight, flight, or freeze. And let's just take a couple of minutes to discuss which of these trauma response adaptations these students might be exhibiting. And I'll give you just a couple minutes to do that. All right, let's take a look and see what we're finding in these students. Are they just being difficult? Are they not suited to the profession of nursing? Or are they having difficulty navigating their nervous system? So if we take a look at Jordan, we find that she's having a fawning response, and as is Riley. We look at Nathifa, and she's experiencing a fight response. She's moving towards the stimuli, whereas Gabby is moving away from the stimuli in a flight response. And then we have Taylor and Chin Mei in varying degrees of a freeze response. And so oftentimes these trauma responses are considered maladaptive behaviors when in fact they're nervous system adaptations. And so again, not conscious choices of the students. So how can we help them? How can we help ourselves to help them? How can we help everybody? Because it's hard. It's hard for the student. It's hard to live in those, I spent a lot of time in all of those responses myself. It's very disruptive and internally, and it also can be very disruptive or challenging to the people around the students, whether it's the patient or the precepting nurse or the nurse faculty. So we're going to pass out a handout I have for you, an infographic, and it's from SAMHSA's Trauma-Informed Care Guidelines. And we're going to pause for just another minute and really take a look at some of these student archetypes or the students that you've encountered in your own teaching practice, and see if you can make any connections between immediate reactions to trauma, which we're all pretty well trained in, but most nurses don't get a lot of training or education in these delayed reactions to trauma. And remember, when we're looking at these trauma responses, they're adaptations that occur over time. So a lot of what you might be attributing to burnout or stress or anxiety or depression in a student, possibly, not that we're diagnosing them, but we are trying to educate them and meet them where they are. But it might be delayed reactions to trauma. So we're not going to unpack all of this today. This is something for you to take with you and really talk with your teams and use it as a tool to teach your students about what they might be experiencing, in the downstairs brain, if you will. So let's talk about some healing-centered practices that you can do yourself, and you can also do with your students and teach them how to navigate their nervous system before we put self-caring practices on top of them. So the first thing to really understand is that the goal here is not efficacy. This isn't a pharmaceutical intervention. This isn't a medical device. Every person has a unique trauma history, and therefore each person is going to have their very unique innate care plan. And so the goal is for us to help ourselves and our students be in their window of tolerance in nervous system regulation. So our goals will be for them to have a safe space where they can ground and center. The second goal is so that signs of safety can be signaled to the threat detector, and how they can use a microdoses matter practice to stabilize and widen that window of tolerance. So the first practice that we're going to do is drawn from the self-care clock strategy. I call it the button jar check-in, and asking yourself and the students, what can I do to support my nervous system right now? And look at that jar of buttons, because chances are, if your sympathetic nervous system is telling you under no circumstance can you even stop, not even for 1 nanosecond. And so really leaning into, okay, what can I do now in terms of the button? So find the smallest button in that jar. And when you have it, take one deep mindful breath. All right. Now, that doesn't take any time at all because you're breathing anyway. So even for the student who's so overwhelmed and overextended and kind of really up in their sympathetic circuit, remind them that they're breathing anyway, and we're just shifting the perspective for a second here. And so forth. You can look at the rest of the buttons, and one of them might be I have 20 seconds, one of them might be I have 30 seconds, one might be I have a minute, 5 minutes, 20 minutes, 40 minutes, an hour, and that the biggest button you see in there, well, that's a weekend retreat. And so it kind of helps us to visually explore through the right hemisphere, which oftentimes gives us rich information as to how much time we have, and to kind of bypass that sympathetic or the left hemispheric brain that's telling you there's no time for me. I can't. Right. So what size button do I have right now? Always there's a button because you're breathing anyway. All right. And now I provide for my attendees this beautiful little swag bag, and this is what I call our microdoses matters practice that can be done in as few as 20 seconds, like maybe even faster, but I'm always talking people through it. I can probably get it done in I think 20 seconds fair. So the first step is to find a private space. Just duck anywhere into any little room, a conference room, a vacant patient room, into the restroom. That's a great place to take 20 seconds. The break room, wherever you can find. The second step is to ground and center, which we're going to practice that in a moment. The third step is to signal safety. This is the mission critical step, because what we need to do is send like a signal to the threat detector. It's the threat detector that is signaling you're not safe. And that could be, again, external circumstances, internal circumstances, or what is stored in the repository. That's why it's different for each of us. And then lastly, and also very importantly, is to honor your healer's heart and all that you are as a nurse or a student nurse, because this is hard work we do, and it just is so tender and caring. So I left space on these slides for you and your team to really start brainstorming, and even with your students. And you're welcome to use this presentation in your classes, that's fine. To brainstorm, like, where is a safe place for me at home or at school or at work or in clinical, right? And start like getting prepared. Where are my private spaces? So when I can feel my sympathetic stress coming online, or I feel myself kind of, that window of tolerance is getting smaller, I need to do a microdoses matter practice and find out where those places are. Now, oftentimes in your kit, you have a pink amethyst, rose amethyst heart. And so artifacts of nature or anything else that helps you or your student to ground, pocket pals. I've had students bring in twigs or leaves or soft blankets, a little square they cut out of a blanket, or an itty bitty stuffed animal that fits just ever so discreetly in a scrub pocket, that sort of thing. So whatever it is, ground and center. And if all else fails, Ground your feet into the earth. Just really connect to the earth, even though you're not in the soil. So those are some examples there. And then signaling safety. And there's any number of practices that are written about in my book. A few of them are here, and many of them will be on my YouTube channel. But some to consider. 5, 4, 3, 2, 1 is a great practice if you're maybe in pre or post, right? After clinicals. 5 things you can see, 4 you can touch, 3 you can hear, 2 you can smell, and 1 you can taste. And also, giving yourself just a bear hug, rubbing your palms together and releasing that energy, noticing and naming a couple of things in the room. I see the white door, I see the blue carpet, I see the computer screen, I'm noticing the fan blowing on my skin, that sort of thing. And a lot of times the physical sympathetic stuff, torso twisting, swaying, bouncing, shaking, any of those things might be really good for your students who are in their sympathetic. And then putting your hands over your heart, and just try that now. Put 1 or maybe 2 hands over your heart, and just notice how that is a signal of safety. And not only is it safety, but it's compassion. It's compassion for what you or for what the student is experiencing. And that's just mission critical, because when that window of tolerance gets small, it's just not it's not fun at all. So let's give that a practice. All right. So in your mind's eye, I'm going to talk you through it. All right. And this won't be the 20-second version, but you can see that you can expedite this pretty quickly once you learn it. So in your mind's eye, find that private space that you can dip into for, say, 30 seconds. Right. 30 seconds. You can take longer. And once you're in there, you might well take longer, but your sympathetic might be telling you can't take 30 seconds. So just dip into that space. Take a deep cleansing breath. Ground and center. By grounding, I mean take the energy from the top of your head and move it through your body, through that central channel, through the chakras if those resonate with you, through your forehead, your throat, your heart, your solar plexus diaphragm area, your belly, your hips, down your legs, down the bottom of your feet, to the earth, all the way down through the soil, all the layers of the earth and the soil, to the star at the center of the earth. And now let's signal some safety. Here you can ground into that rose quartz heart, right? And just feel the textures in your hand. Open your lip balm, which you can do anytime at work. There's lemon verbena essential oil in there for you. So you can do a little aromatherapy. You can either smell it, apply it, or both. And that is signaling safety to your nervous system. And just be with that for a minute. Maybe give a couple of inhalations on the aromatherapy if that feels right, or do a little bear hug, or a little swaying if your body feels like it wants to move a little bit. Just however you can signal safety to the threat detector. And then lastly, place 1 and then the other hand over your heart. And just notice how that brings your stress, your trauma response, but down about 5 notches. And just thank yourself, as I am thanking you so, so much for all that you are and all that you do. And then when you're ready, just kind of, give yourself a little wiggle and focus your eyes around the room. And then you can come out of this. So microdoses matter practice. Super important. I recommend doing it morning and night until you're comfortable with it, maybe in your home. And then I'm big on setting myself little timers to when I'm learning new patterns or behaviors. So every 4 hours until you get into the habit. And then every hour, and you'll start to notice when your window of tolerance is getting a little smaller. That's like microdose it right then. You do have 20 seconds. You really, really, really do. And so do your students, even though that downstairs brain, that sympathetic nervous system is saying otherwise. And then continue to add doses PRN as needed. And it's just a good practice. So let's check in and see where your comfort level is now in navigating your students and helping them with those behavioral responses, oftentimes, which might be trauma responses, delayed trauma reactions. So go ahead and vote there. And it certainly looks like everyone has made some great progress, and that's wonderful. So this is just the best I could offer you in the time that was allotted. I do want to let you know I have a book coming out on these and other topics, in addition to workshops and a community that we're building around trauma healing, and a nonprofit organization that was recently formed called the Healing Academy, which will be our virtual safe space for nurses worldwide to come together and heal through all that we've endured, in particularly the nurse-specific traumas. And within that, there will be a student nurse program academy that will be free to the students, assuming I get the benefactors lined up, which I'm in progress. So there are videos that you can use now on my YouTube. They're a little bit rough because I am hiring somebody to do video production, and there will be a plethora of free resources within the Academy when that is up and running, probably in early 2020. Late 2024 is probably when that's going to be ready. So I just want to thank you so very much. It's been my great pleasure to be with you here today. Please reach out and connect with me however you feel called to do so. Here's a few of the key nursing education references, along with my comprehensive reference list, which you can see on a Google document. And if you want to stimulate more conversation, here's a launching off article to inspire you and your colleagues. So thank you so very much. And until next time, namaste.